response to do so far is helping the CD4 help cancers. But it does a little bit more than that. Cell-mediated immunity is the big work of the T lymphocytes. So we did talk a little bit about how T cells can be, or how human cells, human nucleated cells, can be infected with certain kinds of agents, certain kinds of microbes, like parasites or viruses, and cause the self-antigens to look different. They'll present these viral antigens on the surface and make our own cells look foreign, so that the T cells can go and get them or destroy them. That's cell-mediated immunity. We already know about T cells' ability to secrete cytokines and call other warriors to the area to help the host defend against what's trying to take it out. We already talked about T cells being able to have memory as well once they've been sensitized. A sensitized cell, no matter whether it's a B cell or a T cell, means that it has already seen, it has already been exposed to the antigen that it was born to respond to. And once sensitized, memory T cells can be formed. We already talked about T-dependent antigens and how they work. And this is a pretty cool slide that I've used for many years. Doesn't come from your book, but it's a good slide to show how cytotoxicity, or how T cells can kill target cells. So up in the big yellow ugly thing, we have exposure to some sort of an antigen. And that antigen has been taken into the cell, and it has been processed, and now it has been presented on the surface of the cell. The T cell has recognized it and has responded by secreting cytokines. Now, on this side of the immune system, we're not really interested in the antibody-making part of the system. It doesn't mean it's not going on at the same time, because it is, okay? Just because we're looking at cell-mediated immunity doesn't mean those B cells aren't cranking out and you're trying to make memory cells and plasma cells and doing all that stuff. What we're looking at now, what's the cellular side of the immune system doing when a bacterium, a parasite, a virus, or something has now infected the host. Okay, so the cytokines now can do this, and we haven't talked about this. We talked about the interleukins being able to increase the clone of B cells, make memory B cells, make B cells mature into plasma cells, and make memory T cells. We haven't talked about cytokines also being able to activate macrophages and make macrophages better at what they do. Okay? So now macrophages are also on the cell-mediated side. Although we also know that these guys can act as antigen-presenting cells on the other side, and that's happening on the other side of the immune system. So cytokines can cause activation of macrophages to enhance their ability to phagocytose invaders in an innate kind of way. This is still not specific, although we're talking about the specific side of the immune system. This is not a specific activity. Okay? So we have the cytokines that are activating T helper cells, and then that's going to do all that B cell side of the world that we've already talked about. But now this is the new piece. T cells are going to cause activation of CD8 T cells. The CD4s are the helper guys. The CD8s are the killer guys. Okay? So we're going to activate T cells to become cytotoxic lymphocytes, CTLs. When you see that, you might see that in your book. The cytotoxic lymphocytes are now able to go after target cells. These cells that are now out there and they've got antigens in them. They're presenting antigens on their surface. It could be an antigen. This antigen could be presented on a nucleated cell of the body that's now got virus in it. But the cytotoxic T cells will see the non-self virus and it'll go and it'll kill that, destroy that, cause apoptosis of the target cell. Now, this is going to talk a little bit more about the 4s and the 8s. Okay. We have said that the T helper cells are mostly of the CD4 type. And notice it says T helper cell types 1 and 2. Okay. So these different helper cells are responsible for doing different kinds of things. Notice that mostly Th2s get the B cell side of the immune system running. And the B cells, B cell side of the immune system is mostly involved with making what? Antibodies, exactly. Now, look at the T helper cell 1. And you see it's mostly involved in that thing that we just talked about, making cytotoxic T cells. And cytotoxic T cells will be able to destroy nucleated cells that are exhibiting tumor antigens on the surface, viral antigens on the surface, parasite antigens on the surface. But these are also the cells that are responsible for some of those hypersensitivity reactions that we talk about. You know how when you get a TB skin test and you look for the wheal and the raised and all that stuff? That's a hypersensitivity, a delayed hypersensitivity reaction that's T cell mediated of the CD8 kind. Okay? Now, I'm going to teach you a trick to kind of remembering what's going on with these CD4s and CD8s. It doesn't work all the time, but it works enough of the time that it'll get you pointed in the right direction. Okay? I call it the rule of 8. You'll see it in no textbook usually. Okay? So you got to trust me that this could be helpful. And if it's not helpful, just forget it. Okay? All right, the rule of 8 says T helper cells type 1, although they are CD4 cells, these are mostly, the TD1 type cells, are mostly involved with this, the CD8s and getting the cytotoxic T cells and those things, the T cell side of the immune system going. So we're going to kind of in our mind link Th1s with 8s. And we're going to think about the delayed hypersensitivity and tumors and those kinds of things. Okay. T helper cells type 2. These are, again, these are CD4 cells. But these type 2 are more involved in making antibodies And we know that those B cells that are making antibodies and, making plasma cells and all those kinds of things are responding to help from CD4 cells. So helper cells type 2, CD4s, 2 times 4 are 8. This works for my mind. If this does not work for your mind, let it go. Okay? Okay, so we got a T helper cell, 1 CD8s. And you see the kinds of things that they do. 2s, mostly B cell proliferation and making antibodies. And the helper cells that are involved in getting this B cell side of the line moving are CD4s. Now, we got these cytotoxic T cells involved in graft rejection. Again, these viral infected cells. These are all things we want to kill. These are, we're trying to kill things. We're trying to destroy things. Cytotoxic cells are trying to destroy. These are all the kinds of things that they're trying to destroy. These CD8s are responding to nucleated cells in the body. And all the nucleated cells in the body have what kind of major histocompatibility complex molecules on them? MHC1. So there's kind of our rule of 8. It kind of works. Okay? Now, if we consort, Th1 cells, notice that's the only ones that we can, every time, do you see CD8s anywhere else? No, you really don't see it anywhere else on that side, okay? It's over here, but we're not talking about helper cells. The Th1s, CD8s, that'll help you remember rule of 8. T helper cell type 2s, we know that this is the antibody producing side of the immune system. And the B cell side respond to helper cells that have CD4s on their surface. Okay. Cytotoxic T cells are in the business of destroying cells, destroying target cells, destroying nucleated cells. And these all have MHC1 on their surface, CD8. So that's how my rule of 8s work. It works for me. If it's useful for you, use it. A student came to my office, and this was years ago, and was sort of trying to verbalize this to me, and I was like, huh? And so I really sort of refined it so it can work to be helpful to everybody else. So I share it if it works for you. Okay. Types of T cells. We talked about helper cells, and now we know that there's a couple of different kinds. We know that the 2s have to hook up with the CD4s in order to get to 8, and we know that that's the antibody producing side. And the Th1s, the only way you're going to possibly get to 8 is to know that the CD8s are involved with those. Okay, so it can be helpful to keep you to differentiating the two and what they're doing. Okay. It doesn't mean that the T helper cell ones have nothing to do with CD4 cells. Okay. Just kind of get you oriented, or it can. It works for me. The cytotoxic Ts are CD8s. What's the rule of 8? How does the rule of 8 work for these? MHC1s is destroying cells that have MHC1s on the surface. Okay. Natural killer cells. Now, these are T cells And I think of natural killer cells as the not real smart part of the T cell line. They're non-specific, and they could very well be located in the on the innate side of the immune response. These guys are just running around, bouncing off of things, looking, you know, they're going through the spleen and the blood, and they're looking for trouble. You know, they're just bad actors. They want to turn over cars and break windows, and they're just looking for trouble. And any place that they end up where they see something that doesn't quite look like self, they just decide they don't like it. And then they just start killing stuff. Okay? They don't do it with specificity, they don't do it with antibodies, they don't do it with complement, they don't do it with any of those kinds of things. They just sort of listen out for cues. They're listening for messages in cytokines and interleukins, and they'll just kind of go to where they hear a commotion going on and see what's in that area that they could possibly help to destroy. Okay, so they aren't the smartest guys, but they get the job done. Okay, this is stuff you already know, just a different kind of a picture. And the more you see it and the more different ways you see it, I think the better. Okay? So now we got these things, these invaders coming in. We have an activated macrophage. And we said that the activation of macrophages is also one of the things that the cytokines do on the T cell side or the cell mediated side of the immune system. So we get activated macrophages. They're really good at engulfing things, breaking them down, and then presenting antigen on the surface. And we said a long time ago that our antigen presenting cells deal with what kind of molecules for showing their antigen, huh? Yeah, how do they show them? On what kind of molecules?
MHC.
MHC what? Tubes, exactly right. So the macrophages, the dendrites, and the B cells are all going to do this kind of presenting thing, and they're going to present them on antigen peptide fragment. That just means that the big antigen has been taken in, beat up into small pieces, and attached to the MH2 class of molecules. Now our T helper cells can come along, and now they're going to be emitting interleukins, mostly interleukin 2, into the environment, and these are all the things we know that interleukin 2 can do. Make memory T's. Don't see any B's on this slide, but T1 and 2 type of memory cells are activated. 1s and 2s are activated when this first T helper cell, kind of a nondescript kind of T helper cell, just one with a specific antibody for that antigen. Now with the interleukin 2, they make more and more cell divisions, making more T cells that are ready to do this work for this particular antigen. The 1s, we already said that this doesn't work all the time. The 2s are going to deal with B cells and starting to make antibodies, and the 1s doing the cell-mediated immunity side. So mostly, not singularly, mostly this is CD what type of activity going on this side? CD 4 or 8?
CD4.
start with this one. Mostly CD, which type of T cells are involved in this side? Or, because it's making antibodies, mostly the antibody stuff is involved with the Th2, CD4s, and that's our rule of 8. So let's go back. Th1, mixed cell mediated immunity, mostly, not solely, but mostly dealing with what kind of CDs? 8s, 1s, and 8s. Okay, what's this one? Cytotoxic T cells that we know about, killer T cells that we also know something about, and memory T cells. Okay, so we got our antigen presenting cell, MHCs, antigen on the surface. And now we have activated a T cell that bound some sort of and we're now activating our T cells to form more and more and more of these. Pre-cytotoxic T cells become cytotoxic T cells, and they now can go and release destructive enzymes in the area. Okay? This makes it look like it's a specific reaction, but it's really not. So it's not a receptor specific kind of a reaction. But they go to the area, they can detect abnormal antigens on the surface, and they'll start dumping out bad stuff on them to destroy them. Apoptosis, direct lysis because of the destructive enzyme. Let's see if we know all of this too. Yeah, we kind of know all of this already. We got an APC over here, and it is taking in a new antigen, presenting it on an MHC2, and we can see our co-receptor kind of thing going on. And when the co-receptor is detected, then this CD4 says, okay, now I can release cytokines to get all this other stuff going. We can make memory CD4, memory T cells. We can, what else can we do? We can make both Th1s and Th2s. And we said that mostly Th2s are going to be involved with CD4s, and mostly Th1s are going to be involved with CD8s. But there's some CD4 stuff that happens in here too. It's just a way to help you to orient your mind. Okay. So Th1s and CD8s, that's a kind of a rule of 8 right there. And we have an activated 8 that can now recognize T cells can recognize infected nucleated self cells to destroy them. And these perforins are just lytic enzymes that help destroy cells. So that's kind of how the cytotoxic cell works. And it can just pour out things to destroy the infected host cell, so that if they either directly, again, put holes in it or cause apoptosis of the host cell.
Dr. Anderson?
Yes.
If this picture makes it appear that the APC can present an MHC2 and an MHC1, and I don't understand why. The bottom one has MHC1 on it, and I thought MHC2
Yes,
was
yes. We're sticking to this story. This is something that we don't need to distinguish this.
Okay.
So for our purposes, when we talk about dendritic cells, we're talking about it presenting on an MHC 2, just because it's just simpler that way. Everything else, there's a lot of under the surface stuff that we're just not learning.
Thank you.
Okay, I want you to learn the basics of how to get this stuff going, what types of cell lines are involved, and what the final outcome is. Okay, Okay, we know there are many, 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 many different kinds of interleukins. We're not gonna learn them all. We're gonna learn the ones that are, most prominent, and we'll learn what they do. Interleukin 1 stimulates T helper cells. And the interleukin 1 pretty much comes from the APCs that have taken in, detected, and presented antigen on their surface. And we're gonna say those APCs are MHC2s. It's just easier for us, okay? And those are gonna start secreting interleukin 2. Stimulates T helper cells. T helper cells now stimulated can say, oh, look, there's our antigen that we can respond to, and they bind to the APC that's showing their antigen. And they start to secrete interleukin 2. So the helper cells, once bound, start to secrete interleukin 2, and those are all the cell lines that they can stimulate. Other T helper cells, B cells, cytotoxic T cells, and natural killer cells. Interleukin 4, all this stuff is now starting to be sprayed around in the environment after we got all these things going on. So we can produce more B cells because we want more B cells. We don't want just any B cells. We want the B cells that are specifically going to respond to the antigen that's infecting the host. Stimulate CD8 cell growth. And the CD8s pretty much are going to become what? Yes, TCs, cytotoxic T cells. Differentiation of H2s and MHC class 2 expression on macrophage. 8s bring phagocytes into the area. Really, these guys are, as we come down, we're starting to get to more complicated interactions of what these interleukins do. Differentiation of CD4 cells. Most important for us, 1s, 2s, 4s, and 8s. Remember that we said that there are how many different kinds of interferons? There's several classes back. Interferons, there are a few different kinds. How many? 3. Okay, what are their names? Alpha, beta, gamma. Keep talking, you're doing good. For what? Which one?
I don't know.
Okay, somebody does. You got us a good start. 3 different kinds of interferons, alpha, betas, and gammas. Which ones do what?
Help her.
Huh?
On my way.
On my way.
I'm trying to go faster.
Alpha, beta, gamma. I see one clue on the slide, so.
Alpha, stimulate phagocytes.
Which one?
Alpha. Gamma.
Gammas stimulate macrophages to help them be better at what they do, phagocytosing. So alpha and betas have what kind of activity? Anti-viral activity, right? Okay. A chemokine is just a nondescript. Many of these can access chemokines. The chemokines are those things that say, leukocytes, you need to get over here. We have a situation. Come hither. Okay. T cells and superantigens. We already kind of talked about superantigens, and we talked about how superantigens mean that the stimulate an immune response that's just out of kilter, it actually harms the host because it can overwhelm the immune response. That's what a super antigen does. Okay? It causes an overabundant release of cytokines. It causes an immense degranulation of all of the mast cells and the basophils and all those things that have all of those vasoactive granules and great vasoactive substances in them, so they release them in huge amounts. And one of the things that we know that release of those granules cause is increased capillary what? P word. Permeability. Increases capillary permeability, so capillaries become leakier, and that means cells and fluid can easily leave the vessels. It causes vasodilation. Remember we said the inflammatory response. Initially, the response to the vasculature is what? Vasoconstriction. Very short-lived, however. Then there's vasodilation. When there's a super antigen, there's super vasodilation. And when there's super vasodilation, the problem for the host is what? Huh? Shock. Hypotension before shock. But yeah, you start losing blood pressure, you start losing blood pressure, you start losing blood pressure. And you lose it so much that your patient goes into shock, and right on the heels of shock is death. Right. Well, maybe this will come first. Multi-organ damage, then you die. You die with terrible organs that haven't been able to get any blood. Why is there multi-organ damage? What's the pathophysiology for that in this situation? Hmm? Why is there no blood? Because you have no blood pressure. The blood's just sitting there in these huge vasodilated capillaries and veins that are just sitting there, and the heart is working and pushing and still can't push this all of this fluid. It's like sitting in this big swimming pool instead of having nice firm water hoses. They've just got these big giant pool of blood that can't be pushed around. So the organs are not getting oxygenated blood. They die. Brain dies. Heart's going to fail unless you have all hands on deck and you're trying to get this person pulled from the jaws of death. Cartoons, my favorite. Oops, no, wrong arrow.
Antigens are normally processed by antigen-presenting cells and presented to T helper cells on class II MHCs. Only the T helper cells with T cell receptors capable of interacting with the antigen are stimulated to produce cytokines. The activated T helper cell stimulates only B cells that react with the same antigen, thereby limiting the response to the production of antibodies that were presented. Superantigens, such as the toxic shock syndrome toxin produced by Staphylococcus aureus, are not processed by antigen-presenting cells. Instead, they bind directly to the outer portion of an MHC class II antigen on antigen-presenting cells, and to the outer portion of the T cell receptor of T helper cells. Rather than binding to only the cells specific for that antigen, which represent about 1 in 10,000 T cells, the superantigen binds without antigen specificity to as many as 2% to 20% of the T cells. This results in stimulation of many T helper cells. The result is the release and activity of excessive amounts of interleukin-2, IL-2, and other cytokines that enter the bloodstream instead of only acting locally as they normally do. This leads to symptoms of fever, nausea, vomiting, diarrhea, and sometimes shock, with failure of many organ systems, circulation failure, and often death.
Now, this is a great side. It doesn't mean that the toxic shock syndrome organism Staph aureus is not also being processed by antigen-presenting cells and B cells and making antibodies, but this so overwhelms the system that you can pretty much forget about the antibodies, but because the antibodies can't help them. Even if they're making nice amounts of antibodies that's entering the circulation, this patient is busy dying because of all of these vasoactive chemicals, interleukin cytokines that are being deposited directly into the circulation. When they first start to be deposited into the circulation, the heart is working fine, so it's pumping this stuff all around the place, and it's getting, it's going from being perhaps a local problem to being a very systemic problem, and we get all of this fever first, and these other kinds of symptoms of vomiting and diarrhea, and things are deteriorating very, very, very quickly. And if you remember hearing about toxic shock syndrome associated with super absorbent tampons and women, leaving these things in for long periods of time because they were super absorbent and you didn't need to change them very often and you were good. Well, all of the Staph aureus organisms were like, hey, this is really great. We're in here, we're cozy, we're warm, we got all these proteins that we can metabolize, and they make more and more and more and more of themselves, and the organisms, as there are more and more of those organisms, they start to do this thing locally. And the cytokines, although local in one being made locally in one part of the body, enters the circulation very easily. Like we said, the circulation, the heart, everything's working fine until you reach this critical level of these interleukin cytokines, all that stuff, until the patient is in danger of dying very quickly. We'll talk about that in a minute. I wanted to ask if some people came in and told me about their experience with monoclonal antibodies. Anybody else had any experience with monoclonal antibodies in their lives or in family members' lives? Well, I'll tell you one. I've had a couple of students who said, yeah, I have really, really, really severe asthma. And so bad that I was just wheezing all the time. I always had to have my inhalers. I tried this therapy and that therapy and the other therapy. And finally, just had to say, I gotta be able to breathe. And started a monoclonal antibody that would work against the degranulating mast cell activity. Really, really, really expensive treatment for asthma. I mean, usually the regular, ordinary, prednisone, basal bronchodilators are not that extremely expensive, but when you get to the point where, we gotta do something drastic, and got some improvement. And if you have grandparents, grand-aunts, older people in your family with really bad rheumatoid arthritis, you may have heard of Remicade. That's one of the things that it's used for. Also being used for inflammatory bowel disease. So it's becoming more and more commonplace to know of or to have heard of somebody on monoclonal antibodies. Obviously, it's not easy. You can't just go and, turn on a machine and, start cranking it out like you do aspirin or ibuprofen. So it's very expensive, and usually it's one of the last therapies to consider because of the cost and because of the possible side effects, because these things are made in mice, basically. So you have to consider the possibility that your immune system isn't gonna like it. Nobody? No?
Friends, I bet.
You have?
With Crohn's, yeah.
On which drug?
I wanna say Humira, but I'm not sure.
Okay.
Could be Remicade as well.
Yeah. Okay. Immunization, then we've all had immunization. And passive immunity, we've talked about this already, like we talked about the, I don't know, a snake bite or a tarantula bite, and you have to give an anti-venom pretty quickly. And where do you get it from? From other people who have been exposed and have antibody against this thing, against this poison, against this toxin, and it's injected to you passively. It means that you didn't make it yourself. That's what passive means. Active immunity means your body made it. The artificial means that it was injected into you. You didn't come by this anti-venom in any natural way. Treatment of choice for preventing measles, hepatitis A, and replacing antibodies in immunodeficient patients. Well, you notice it's the treatment of choice for preventing measles in a person who has already been exposed. So if you are a pregnant female who has been exposed to someone with measles, you're unimmunized, or you don't have protective titers, like we talked about before, and you don't want to chance the baby being exposed to virus that crosses the placenta. You can passively get passive protection by having an injection of antibody. Hepatitis A, hepatitis B. If you need protection right now, we can't wait for your immune system to go through all the IgM and IgG and all that and get to the point of having protective titers. Sometimes that's the way of protecting and treating a person. Remember that passive immunity acts quickly. That's the good thing about it. The not so good thing about it is that it has a half-life and it's going to be gone in a few months. So if you ever have that same exposure again and haven't put an active immune process in place, you're going to be in the same position again. Next time you get a spider bite or get exposed to measles or whatever, you're going to have to go through this thing again, because if you don't actively make the antibody, you don't have any memory, you don't have any plasma cells hanging out in your bone marrow to protect you the next time. Notice the third bullet point says that the sera for antibody against diphtheria, botulism, and some of those things are made in horses. So you may have to deal with, you'll have antibody, and that's a good thing, but you may have to deal with serum sickness, because your body is saying, there's something now in my circulation that's not me. It's not even my own species. So we're gonna mount a response against that. So I'm gonna get fever, you know, all kinds of, symptoms that may be associated with the fact that you're alive, and that's a good thing, but you still it may not be a totally benign way of treating, whatever your exposure is. Artificial active, that's what an immunization is. You artificially get it because they put a needle in you, but it's active because your body makes it. You'll have memory, and the protection will be long term. Response to a future exposure to a bad thing. You weren't exposed to the bad thing, you were exposed to a portion of it, an element or a killed or a inactivated form of the bad thing. Should you now be exposed to the real live pathogen, you already have circulated antibody to it, and you have memory to it, and so you'll have exposure because of what's in your circulation, and your own immune response is gonna jump into action and make brand new IgG to get you through the exposure. Okay, we'll talk about vaccine history. Mañana. Almost finished. Long haul.